Hello.
Welcome, everybody. My computer has, as of a minute ago, started to freeze. So give me a minute. Can you hear me okay?
I can hear you.
Yep.
Okay.
Yes, we can
Perfect.
hear you. And my computer did the same thing 5 minutes ago. I just barely had enough time to restart everything.
I'm like, really, computer, right now? Why? Give me just a minute here. Okay, it seems to be catching up to itself. Well, welcome, everybody. I'm just admitting some folks. Let's see, who all do we have? Susan, hi Emily, Gary, Graham, Maite. Did I say it right? Maite? Ross. Robert, are you in here twice? Is that you?
That is
A
me
lap
twice.
a laptop? Okay.
Headphone and laptop. Yeah.
Thanks, Maite. And I know, Maite, you're having microphone and video issues. Is that right? So you'll be chat only. And Trevina, thank you. All right. Well, let's go ahead and get started.
Hmm.
I'm going to share my screen. Welcome, everybody. I have been counting down the days for this class to start, and I've been watching the introduction polls roll in, and I'm excited to share with you some findings from that. But let's go ahead and get kicked off. So, welcome to the first day of the Health Data Innovators Bootcamp. This is a 9-week program. We're meeting every Monday and Thursday from 3 to 5:30. Hopefully we'll get some good time peppered in there for some breaks and some working time together. And we're running from now until the end of March. So it's going to be fast and furious, and there's going to be a lot of information. And one thing that I always like to say is that healthcare is the most complex industry. And I may be a little bit biased, but keep in mind that you are learning a foreign language. We are going to cover a lot of information. It's going to feel like a lot. I will be available to talk one-on-one with you all, and we'll have lots of hands-on time. All of our notes and everything will be made available, but we're going to learn a lot of really cool and fun stuff. And my goal is to put everything into real-world application. So we'll talk a lot about concepts and things like that, but my goal is always going to be translating that into how it's actually used in the actual industry and how you can use it, going forward. So one thing about healthcare, and it looks like many of you may be new to healthcare, is while it's the most complex industry, in my opinion, um, there's just tons of opportunity. So some of the questions that we got about, the goals of this boot camp and what we're preparing folks for, there's so many different threads in healthcare that you could go down and learn about and become an expert and devote your life to. I've been in healthcare for 15 years now, and I'm still learning something new every single day. But what that represents to me is a lot of opportunity for all kinds of people and all kinds of skill sets. And so, as I get to know all of you and as we talk one on one, I'd love to hear more about, what kinds of things are interesting to you? What kinds of skill sets are you thinking about going to work for a startup? Are you thinking about a healthcare system or whatever? And let's talk about the roles and what kinds of things you might be interested in pursuing from here. So while I can't answer just yet what it's going to mean for you, because that's going to be a very personal thing, I'm here to help you all figure that out, and then hopefully connect you with some folks who have some opportunities for you there. So let's just start. I'd love to introduce a little bit more about my background, and I'd love to introduce my co-instructor and some support on her side. So my name is Stephanie Garadia. I'm the lead instructor for this course. That's kind of the blah, blah introduction, but the long and short of it is that I've been working in healthcare and Medicaid for the last 15 plus years, tons of data and analytics. I had a company I started, company was acquired, so I'm also an exited founder. I've worked all over New Mexico, from health plans to healthcare organizations and all over the nation with federal programs down to independent providers and everything in between. So everything that I share with you all today is going to come from that sort of systems perspective. I'm always taking a very systems wide perspective and approach, and you'll see that reflected in everything that we do. I would like to introduce Mary Kratz. Mary will be instructing or mostly instructing. I don't know, we have decided you might have another guest instructor to our guest instructor, but weeks 3 through 8, 7. I don't know, 4 weeks sometime. Mary, would you like to give a little overview of your background? Say hi.
Very good. So thank you, Stephanie. We're really excited to be here to support this boot camp. Mary Kratz, I have been in the healthcare industry my entire career. So probably before even many of you were born. Started with a licensure in laboratory medicine, working in both research and clinical labs. Transition to the health system, building some of the initial homegrown electronic health records where we sat around a table and said, well, put the patient name in the third field. No, I want to put it in the fifth field, which took me to both participating and then leading some of the data standards organizations that standardize on how we structure and how we make healthcare data interoperable. Wasn't satisfied with that, so I took a stint leading the healthcare initiative of the Internet to Academic Consortium, which is all of the people who built the internet and how do we apply these technologies to different and various business models. Was recruited out of that role to work for the U.S. Army's Telemedicine Advanced Technology Research Center, where I built and managed a technology portfolio of research activities, a lot of high performance computing, what we know today is artificial intelligence, big imaging, surgical simulation activities, and then pivoted over to the State Department and the Global Health Initiative and built and deployed in about 40 different low and middle income countries, mostly in sub-Saharan Africa and Latin America. From there, I was recruited into my current role with the Interoperability Institute, which is an innovation arm of a group of affiliate companies that run all of the state health information exchanges. So all the data that's required within a state to report communicable diseases to the CDC, to report financial and clinical data to Medicaid and Medicare programs, facilitating all of that data that runs the health system. And I am delighted today to be joined by my colleague, Emily Mata. Emily's been instrumental in putting together and making the content that we'll be training on interesting and engaging for the learners. So Stephanie, I don't know if you want Emily to take a minute here and introduce herself
Yeah, that'd be great.
Hi, everyone. I'm Emily Mata. I'm really excited to be a part of this course, and thank you, Mary, for your kind introduction. I'm the Vice President of Marketing and Communications for Velotura, which is kind of the Interoperability Institute's parent company. And I've worked in health information exchange for almost 6 years now, but prior to that, I kind of worked at the intersection of public policy and public health. So what we have prepared for you is really relevant to what's happening today. And I think that you'll find great value in it. So I'm happy to be here, and I hope you all enjoy the course as much as we've enjoyed putting it together.
Thank you both so much, and that's awesome. I didn't know that about your extensive background, so that's great. And so the way that the course will work, we'll talk a little bit more about the week-by-week curriculum, but I will be teaching the first 2 weeks, and then the next 4 weeks will be the Velotura team, possibly bringing in some guests as well. Haven't decided just yet, and then I will take it over for the remaining 3 weeks on the tail end of that. So we are very excited to have their expertise on interoperability and on all of the good things, because as you will see, Mary, here in a minute when we talk about the intro slide, a lot of folks are really interested in learning all about that, HL7 and FHIR and all that fun stuff. So we'll talk more about that. All right, so I want to just start with some general housekeeping. So we'll spend a little bit of time today just sort of getting to know each other, kind of talking about some of the background of the boot camp and how we're angling this towards the CAHIM certification, and just getting caught up on all of that. And then we do have some lecture time prepared for the end of class. We'll see how far we get. But just to align, as I mentioned, we are doing twice a week, 2 to 2.5 hour lecture slash learning lab times or class time, basically. I don't know if we'll stay till the full 5:30 every single day, but the reason that we chose the times that we did is because for the CAHIM certification, you do need to have had at least the 45 full hours of instruction. So that's what it's timed around. We'll have some hands-on work in our learning lab and with our sandbox and things like that. We'll have some conceptual and some lecture heavy courses all sprinkled in together. We do have a capstone for the class. I called it a capstone deliverable. We'll go over that here in a little bit, but the way that that works is week by week, you'll chip away a little bit at it each week. And for the most part, they're somewhat aligned with what you'll be learning in class, but there's also some additional things that you'll be learning to do through the capstone work that we may not talk about in detail in class. And so we sort of have some parallel tracks, again, just to maximize exposure and learning to a lot of really applicable topics that you'll need and encounter in the real world. And my goal with the capstone is, much like in healthcare, is you come and you get a new job, and then the first thing that they give you is something that you've never done before, and you're like, I don't know what any of this means. And so it's a little bit of research, it's a little bit of practical and critical thinking, but it's all, again, just with the goal to really applied use cases and really practical learning. We have a number of readings. Every week we'll be uploading information into Brightspace. I started shelling out weeks 1 and 2. I'm still working a little bit on that. The resources, sometimes I'll post videos, sometimes I'll post articles, data sets, and stuff like that. If there's something that I really want you to look at or read, especially before next class, I'll let you know. Otherwise, I'm really just trying to make a repository of resources for you, both to get through the class, but also to help with your capstone, and also just for you to have in general as future healthcare practitioners. So just know that not all of that is necessarily required. You can go as deep, or as high level as you want in this course. Because the course is, it's not a 4-credit course, which is great. It's a complete or did not complete. At the end of the course, I will report back to CNM Ingenuity about attendance and who came to which classes and things like that, but there's no grades, and so the learning that we put together is really for you, and so you can go as deep into this and get into it, or as high level as you want. I'm here to support you. For those of you who do want to go deeper and really dig your teeth into some of the stuff, I'm available to talk a little bit more outside of our class time. And help you do that. Again, I just want everyone to be able to get out of this what they're really hoping. And I know many of you have some very lofty job aspirations and career changes and all kinds of really fun stuff coming up. So I'm here to support you best I can. As far as communication, I think email is probably the best way to reach me, and probably for you too as well. Oh, no problem, Abdu. Probably to reach you as well, Mary. You can also send discussions through Brightspace. I will be, as I mentioned, holding dedicated office hours. We'll talk a little bit about that. I know many of you are currently working right now, and so I'm going to make myself available. So we'll talk about what kind of office hours times make sense. And if you miss something, as I mentioned earlier, recordings and all of that good stuff will be in Brightspace. So all of this will be available to you to do with as you need. Oh, good question, Abdul. When I talk to the CAHIMs, I'll get to that. Thank you, though. Keep them coming. So what I would love to know, just as we're getting to know each other, maybe just enter in the chat, and I'll keep going through our housekeeping here. But tell me about your participation style. Do you like to primarily participate by chatting through the chat box? Do you like to unmute and interject? Are you more of the type that's going to raise your hand and wait to be called on, or wait till there's a long silence and then you'll pop in? Just help me understand. And my goal with it is that because everyone probably has different communication styles and different comfort levels, I want to make sure that we're respecting all types of learning. So yeah, feel free to pop that in the chat. And if I start cutting out, someone let me know, because for some reason, again, my computer's deciding to hit the bucket here. Okay. As far as the virtual etiquette, it's really hard to do online, 2.5 hour class. I would love if everyone could have their cameras on when possible. Of course, it's purely optional. I just have found in my last 10 years working remotely that it helps with connection and just getting to know one another. I like to pop on and off, if you're eating whatever. No pressure, but I'll just make that plug that please do cameras on when you're able. I will encourage everybody to come curious, not perfect. We'll talk a little bit about everyone's different background, but this is going to be a little bit of a challenge because all of you have great background and expertise in all different areas. And so sometimes some topics might be a little bit something that you may already know or have been exposed to. Other times it may sound like I'm speaking a foreign language. So it'll be hard to course correct the content perfectly for everybody and not consistently speaking over people's heads and not consistently being too basic with it. But, I just ask that we're all here to learn from each other. So we're going to do our best. And if there's something not working, let me know. If you have something to add, because this is your particular area of expertise or background, like please chime in. Like we're very, I'm hoping that we can create a very co-learning environment to learn from each other. And last, I'll just make again, kind of going back to what everybody's popping here in the chat. Mostly it sounds like people are feeling like a mix, but just being thoughtful of giving and holding space for all the contribution styles. And I like to give long pauses when I ask a question, because sometimes people don't like to chime in until there's been 20 seconds of pause or whatnot. So being mindful that if we're the type that's very comfortable to pop in and answer questions, that maybe we give some space for others to answer and things like that. And trying to contribute and be inclusive by chatting as well through the chat box and stuff, just creating multiple ways that everybody can feel included and contribute. All right, I will stop there. What questions? Oh, Robert's off camera because of that. Any questions about any of the housekeeping stuff that I missed? You can pop it in the chat or pop off mute and let me know before we go on to our next. Susan, I saw you come off mute. Was that just because you were off mute or did you have a question?
Oh, no, sorry, I was just off mute, but I was gonna put in the chat that Francis helped me get my CNM EDU fixed. There was a typo in my number, so he reset it and we're good to go.
Oh, good. Thank you. And actually, thank you for that because that just reminded me that Abdu found the hard way that you may have to use your full name at student.cnm.edu to get into the Brightspace. So if anyone's still having trouble to get into the Brightspace, please test it today and let me know. And I'll connect you with Francis if you're having trouble to get into your CNM login. You have to get your CNM login first before you get into that Brightspace where all the content is. All right, so going on to my next slide here. All right, so I want to talk a little bit about who's in the room, and hopefully y'all read all the emails and everything and we're prepped, and we're going to do some round robin introductions. Nothing fancy, super deep, nothing high pressure. I just, tell us your name, tell us what you do or what you're hoping to get into, why you're taking the course, what you're excited about. And then I would just love to hear what is your most commonly used emoji or reaction emoji and get us to know each other a little bit better. I'm just going to go down my list and call out on people. Let's see, who do we have here? Let's start with Gary.
Hello, my name is Gary Lang. I am actually a stay-at-home dad at this point. I just recently became unemployed. After 35 years in the food and beverage industry, it's time for a change. Time for a change, looking out for my family. I have young kids. I have a 6 and an 8-year-old. My 8-year-old daughter is medically fragile. She was born with half of a heart. So she's had many open heart surgeries. So this is also going to give me a little opportunity to learn more about the healthcare industry. Thank you. Oh, and my emoji, praying hands, I guess.
Do you use it to say thank you or do you use it to pray?
A little both.
Nice. All right. Thank you,
Universal.
Gary. It is one of those good universal emojis. Thank you, Gary, for being our brave first one. Thomas, I saw you come off mute, so I'm going to call on you.
Wait, is this going through? Hello?
Hello, can you hear us?
Yeah, I've been listening to the lecture so far. So, where do I start? I was actually just testing out the my headset. I didn't mean to like turn it
Oh,
on and
no
off.
problem. Well, since you
Yeah,
have the
but
floor, you want to tell us a little bit about yourself and why you're taking the course?
yeah, right now I'm a service desk technician for the local school district APS. I'm in a contracted position, so basically this is one of my ways of trying to kind of transition myself into a more full-time role, if you will. Aside from that, I have like zero background in healthcare, but I do have some mostly like just personal uh, self-study background in like things like programming, coding, web dev. Took the web dev boot camp with CNM Ingenuity early 2025. Finished that in April of 2025. Yeah, and then this is my second boot camp after that. But I think that's about all I have to say for now. And as for emojis, I guess I just use like the generic thumbs up a lot, like as part of my work and some of the group chats we have between the different IT teams here.
Stephanie, you're on mute if you're responding. Happens to me all the time. Thank you for that. Ms. Trevina, do you want to go next?
Sure. I was actually getting a little bit of anxiety waiting, so thank you.
Sure.
I'm Trevina, and I'm actually unemployed too, Gary. This is a wonderful opportunity because the option you gave us where it's like, if we want to dive deep, I'm totally taking you up on that. I'm taking it as an opportunity just really to dive in deep. I come from the tech sales side. From an academic perspective, I'm degreed in organizational development. And I was working in tech sales, got laid off middle of December. And this boot camp was like one of the options. And I thought it would be perfect because in tech sales, my client was on the state and local government healthcare side. And so often I would have to talk through a lot of the issues that they were having without knowing a lot of like the technical landscape. And so I'm excited to really dive into that, to be able to speak to it a little bit better. My goal, like if everything works well and this is a good fit, would be able to pivot my experience and my consulting to really be able to speak to some of the challenges that I saw, but didn't have the background to connect the dots really. And then my most used emoji is probably the heart. I a heart for like, okay, a heart for I love that idea, a heart for I got this message. I will send a heart. I used to do a thumbs up, but people would be like, I don't know what that means. I don't know if I thought thumbs up meant okay. So now I do hearts all the time. Nice to meet you all, by the way.
That's awesome. Yeah, someone told me a thumbs up was like they thought I was being passive aggressive or something. I was like, what?
Yeah, a 13-year-old told me that thumbs up is like snarky, maybe. I don't know. So
That's, to be honest, this is part of a thought experiment, which is why I added this question, because I was like, I want to hear from people and see if I'm off my rocker. Thank you, Trevina. That's awesome. I'm super excited to have you. We will, I'm sure you and I will be talking a lot. All right, let's see who else we have. Abdul Wakil, do you want to go next? Do you prefer Abdul or Abdul Wakil?
Abdul Wakil Pablo that's my
Abdul
first
Wakil.
name.
Okay,
Yeah.
Abdul Wakil.
Yeah. The two E's you can, I mean, the I you elongate it, so it's like Wakil. So that makes it
Wakil.
easier. Yeah, because like some people pronounce it Wakil
Oh,
or yeah, yeah. So,
Abdul
but you
Wakil.
did great. Yeah, yeah, Wakil. So my name is Abdul Wakil. I graduated from the University of Maryland, College Park, in August with MHA, so Masters in Health Administration. I pivoted from engineering, performance optimization in cellular networks, and I also did some testing at transport, quality assurance stuff. That which in Albuquerque, it's at the Balloon Fiesta. There's a track there that they do tolling stuff, and so that has like a lot of different parts. I chose healthcare because of its complexity, and taking the course because of that. And I seem to do a lot better with like things related to data, programming, uh, analyzing, innovation, technology, all the things that you described in your course description. So it's like all those are things that are interesting to me. Even though I'm kind of like sometimes I get bored with that stuff, but it's all interesting. Like that's what I like to do, I guess. And I'm taking it primarily for marketability. I mean, like you have an MHA, so it's like everybody who graduates from any level of schooling, it's no experience, too much experience, not the right experience. So I figure like certification in a course like this uh, will help for marketability. And then I listed my favorite emojis in the chat. I don't know how to describe them. So
I saw that. I was like, wow,
I
quite emotive.
yeah, it's kind of like like a lot of sarcasm there. Like yeah, whatever. Yeah.
Oh, I thought it was like a nerdy, like glasses kind of vibe, which I was into.
Oh yeah, yeah. Yeah, it could be that too.
Cool. Thank you very much. Awesome. I'm excited, and we'll talk more about what what you're hoping to get out of it. You bring up a good point. Obviously, there's only so much you can accomplish in 9-week boot camp or even a 2-year MHA or 3-year MHA or whatnot. But there's so many different areas of healthcare now to get into that there's like a flavor for everybody. And I think a lot of times people may not even know that there's an area for them. And what I love, and you guys will all see, is got a lot of folks who are really into data and technology and innovation. And that to me, that's just such a huge opportunity and a much needed one here in the state. So I'm excited to talk. As we go, I'll try to pepper in a little bit more about what kind of roles this means, or what kind of titles, or what kind of areas, because there's just so much beyond just what a lot of people think of for healthcare, and even healthcare administration in many cases. So thank you for that. All right, let's see. Angie, you want to kick us off next? I'm sorry, I called you Maria earlier because I saw that. Sorry about that. You're probably wondering who I was talking about.
It's okay. Hello everyone, my long name is Maria de Los Angeles Munguia Suarez. It's a Spanish name. So, but many people just call me Angie. And I am a student for early childhood education. And I've been through a data chat conversations for the early childhood, studies. And so right now, I don't know if you have heard about the universal child care that is in New Mexico. So the state, especially the early childhood education department, is having they collect data from teachers, and it's like a kind of interesting thing to know in what position is New Mexico at education, health, how many families they are providing these services for universal childcare and all that. So I thought that was very interesting to enter in this boot camp. Just regarding those data chat conversation I went before with the early childhood coalitions in Albuquerque, they are using the model for the UCLA model to collect data, and many questions just around that. Why they are using a California university to collect data from New Mexico. So I thought it was interesting, and just as a key point for our teachers to understand how data can change policies regarding New Mexico early childhood. I'm also part of parents who advocate um, for parents who might have children from 0 to 5 to advocate in the roundhouse like every year, and especially we're going to have a early childhood day in February 14 in Santa Fe in the Capitol, the roundhouse, and so that's why I'm here. I think that is very important. But many people don't know, especially in our field in early childhood, they don't know how to interpret data collection. And also for the health field, probably it's very easy to compromise HIPAA, information. So that's the reason why. And my emoji that I always go or I mostly use is the praying hands and just happy face. Thank you all.
Thank you so much, Angie, and thank you for sharing all of that. Sounds like you'll be busy for the next month during session with all of your advocacy. And it reminded me, I think this Wednesday is also Public Health Day at the Roundhouse. So if anything Angie talked about with policy and advocacy appeals to you, especially in the health and public health sector, let me know if you want more information on that, and I can send that to you. Angie, this is awesome. I'll do my best to try to tie, as many of you know, and as we'll talk about later weeks, healthcare is one aspect of it, but it's influenced by so many other things, what we call the social determinants of health. Many of you may have heard that term before, but these are things outside of the healthcare system, like education and policy and transportation and food insecurity and all kinds of structural and systemic type factors that inhibit not only good healthcare, but also just good outcomes in general. And a lot of times we see them working so hand in hand. So I would encourage you for your capstone, let's think about something that we can tie to your early childhood and education interests to intersect those worlds. And I'm happy to talk through that more.
Thank you.
All right, sure. Thank you, Angie. Graham, you want to go?
Yeah, definitely. Hi, everyone. It's Graham Chason. I'm been in public health for about 4 years now, working for the New Mexico Department of Health as a data manager and surveillance system epidemiologist. And before that, I got my MPH at UNM. And so I'm definitely looking forward to, the data piece of this course, as some mentioned. Really interested just to keep learning HL7, fire, and dig into more interoperability types and approaches and even policy around some of that standardization. So yeah, and then I'm just looking forward to taking a certification and kind of putting that on my resume as I've been working with some of this stuff and just bolster my career that way. So yeah, really looking forward to it and happy to meet everyone so far. I guess my most used emoji is probably the heart because I just double tap a lot. I don't ever open the menu up, but yeah, I do like the cowboy hat emoji every once in a while. Thank you.
That's a new one. I feel like I'm underutilizing these emojis. All right. Thank you, Graham. Yes, and Mary, Graham had a lot of really good questions even before the class started about HL7 and fire and all that stuff. So I think you'll really enjoy those weeks, Graham. One thing about public health and healthcare, it's interesting, and I'm a doctoral student. I forgot to mention this earlier at the UNM College of Population Health, which is basically their public health college. And so we do a lot with the Department of Health and things like that. So we have a lot of people who are in public health. And I have sometimes felt, because I have come from healthcare, which sometimes the public health people call like health systems or health services. I've sometimes felt like the language is still, even though we're both in health and healthcare, sometimes I feel like the language is really very different. And so we'll be focusing a lot on healthcare and the business of healthcare and the systems of healthcare and stuff like that. So I'll be interested from our public health folks to hear how and if this aligns with your work and what you hear. But that is something I've noticed in my work. All right. Thank you, Graham. Paras, good to see you. You want to go next?
Hey, Stephanie, and hello everyone. I am Paras Khanal, and I'm a graduate student of data analytics at New Mexico State University for the second year. And I had about 5 years of experience working in public health. However, that experience is all outside of United States. And Stephanie has been helping me to understand US healthcare since the day I met her. So I look forward for this course to understand more about the US healthcare, to deep dive into the systems and understand more for my upcoming career changes. So happy to be here. And my favorite emoji is that's repeated, I guess. It's also prayer. And prayer is, by the way, I just want to mention that I'm from Nepal, and there we have this greeting. It's just a normal greeting. So we do like this and say namaste, just like a hello here. So I like this emoji whenever I see someone else sharing like this. So really happy to be here with you, Stephanie, with all of you. I look forward to getting great lessons from this course. Thank you.
Thank you very much. I love that. Yeah, another use of the prayer emoji. Great. All right, let's see. Oh, Mr. Robert Sitek, how about you? You want to go next?
Sure, as soon as I can figure out how to get myself off of mute. There we
The
go.
struggle of our time.
No kidding, right? Technology. Yeah, so I'm logged in twice. One is, of course, off, how do you say, off my iPhone, and the other one off my laptop. And my laptop keeps telling me I have low bandwidth, but the iPhone is working just fine. Of course, my video's on the laptop. We'll see if that works. Anyhow, thanks for having me here, and nice to meet everybody. Yeah, my name is Robert Sitek. I am the let's see what I currently do. I am currently the lead instructor for the data science bootcamp here at CNM Ingenuity. And yeah, my background is very much in data. Historically, my formal background is actually in biochemistry, and I've been in the research side, healthcare side, biotech side of a lot of different industries. And so what's interesting in my healthcare journey, though, is that I would say I have fairly deep understanding of a very narrow scope, right? So I'm very familiar with diagnostics and developing assays and analyzers and things like that. But as soon as you get outside of the clinical lab, I know little to nothing about the rest of the healthcare system. So that's part of the reason why I'm taking the course is to understand more that, how do you say, how all the pieces fit together, and when they don't, why don't they, and what can be done about it. So that's the reason why I'm taking this course. And of course, to meet everybody else's or everybody else here and find out what their interests are, and see if there's some way we can team up to tackle some of the challenges that exist. As far as my most used common emoji, I would have to say thumbs up. Just because whenever I click on the emoji, it is the first one there and it captures what I want to do. Now, one day I'll figure out how to sort the emojis so I get some variety in the emojis that I pick, but I tend to be pretty lazy, and it captures what I want. Like, yep, that's good. Let's go. Okay, all that fun stuff. Keeps it simple.
Thank you. Wow, I am learning so much about you all, even just from your emoji choice. This is awesome. Cool. Thanks, Robert. And were you the one asking about building data pipelines and all this fun stuff, or was that someone else? I don't think we'll be going that deep to actually build those pipelines, but my goal is to give you a really good, firm understanding of how those things work, and so that you could construct something like that after. afterwards. But yeah, I'm excited to have you, and thanks for joining us.
Yeah, thank you.
All right. And last but not least, Susan, I have you here on my list. You want to round us out?
You bet. I was going to try to turn my camera on here. I've got kind of like a bandwidth problem too. So let's see. My camera will come on.
Oh, good. Maybe it's not me. Maybe there's something going on more broadly.
Yeah, Susan Ropp, and I work at the Department of Health too. I work closely with Graham, and I feel like I have several things in common with a number of people here. One that I started out, in the lab too. I was molecular biology, and I worked for CDC and developing diagnostic kits. And then for several years, my husband and I owned our own engineering consulting business. So we've kind of had that. And several of our employees were from Nepal, which is a beautiful country, and still very good friends with our friends from Nepal. And now I've started working during the pandemic with the Department of Health. And the programs that we work with collect data we have a lot of relationships with the hospital to collect de-identified data to try to understand the courses of various diseases, respiratory diseases and outbreaks, and try to follow those and see who's at risk. And so a lot of that is very manual. And so we're trying to automate more of that. And, it's a big burden on the hospitals. It's very important, but it's a burden on the hospitals. So as part of my role, I want to try to automate that and take some of that manual burden, both off of the facilities, but also the Department of Health. So I'm very interested in that. And I recently kind of worked on a fire project with the HIE. So.
Oh, excellent. And what is your favorite emoji? Something lab related?
Oh, well, no, I probably overuse the smiley face and the hearts because I feel like sometimes I'm always messaging and so business-like. And so I always throw a smiley face on there just to say I'm so friendly. But
I know.
Yeah.
I have to do it to soften my tone.
Yeah.
I'm not trying to be rude. I'm just, yeah. Awesome. Well, thank you, Susan. Sounds like you'll have a lot of questions and stuff to chat with Mary and team about as they get deeper into that, our standards and interoperability and all that. So super exciting.
Thank you.
All right. Well, thank you everybody for that. That was just kind of to warm us all up. And, like I said, chime in however you want, participate as much as you want. I mean, the more we can get participation, the less I have to talk at you, but I certainly can fill 2 hours with, talking. So it's kind of choose your own adventure. But that was awesome. Let me see what I have here next on our polls. Why don't we, oh yes, should we buy the book? Okay. Yes, let me get to our Kahim stuff. The short answer, Abdul Wakil, on that is just that it's going to depend on how much you want to go into, how much you're planning to do for the Kahim's exam. I have the copy of the PDF copy of the book that when we meet one-on-one, we can look through it and we can decide if it really makes sense or if there's some way that we can pluck kind of the pertinent stuff out of there for you. But you don't need it for this course. So don't worry about buying it, for what we're going to do, but we'll talk about if you want to do that more formally for the Kahim's exam. And I'll talk a little bit more about that when we get to that section. And thank you for the reminder. I have like a few different windows open here generally because I'll have, Excel and all this stuff to show you all. So please do also always feel free to chime in on the chat or chime in and interrupt me. I am not offended at all if you have questions or things to add in there. Thank you. All right, so I want to get through just a little bit more about kind of some background, and then we'll talk about the Kahims, and we'll take a quick break, and then we'll dive into diving into the content. So we got folks from all over New Mexico here, which is awesome, but everybody is from New Mexico, so I'm going to try to ground all of our stuff in a New Mexico context as best that I can. I'm super excited that nearly 50% of the class considers themselves advanced with data, and even if not advanced, has some exposure and up. And so the reason I haven't really been uploading, especially week 2 and some of the future weeks, is because I wanted to see where everybody was at and how deep we want to go. But it looks like a lot of people are really comfortable with data, at least Excel and some of the use cases we could do in there. Some folks even with SQL and some other languages, but it's good to know we're in good company with fellow data practitioners mostly here. I'll give everyone a minute to kind of look at this. This just shows sort of a comfort level with the different skills. Of course, you all took this intro poll, and these are kind of how the results shook out. But I mean, I think by and large, most people are really comfortable with data, interpreting graphs, and presenting insights. Even, to some extent, cleaning messy data, probably a little bit less on the SQL, and that's okay because we're not going to go too deep in SQL. But I will provide some tools and resources and maybe some scripts if you're kind of like curious about getting more into that language specifically. I'll say that having worked in healthcare for so long, um, certainly there's a ton of data. Certainly it's a ton of Excel work, sadly, but it's the truth. And then SQL is probably, or what I call SQL, is probably one of the more common languages that we are seeing. By and large, we are starting to see a little bit more Python and some R, but I would say that that is an important skill set. So if that's of interest to you, let me know. We can think about some dedicated resources, or maybe I can create some specific resources for you too. And just as far as healthcare, a little bit more skewed the other way, where most of us are actually just somewhat or maybe new to it. And so, we're all in good company. We're all going to be learning this foreign language here together. And then in terms of, Mary, I thought you might find this really interesting in terms of what everyone's most excited to learn about, certainly technology there at the core, but a lot of stuff about fire and HL7 and, interoperability and all the coding standards and all of that meaty stuff. And so we'll definitely get a lot of that here. And let me just give a quick overview of our roadmap. Some of you all have seen this in some way, shape, or form. I think I sent it to some of you before class, but some of you haven't. So this is kind of how the 9 weeks are laid out. So week 1 is high level, very broad, very system level view of the U.S. healthcare system. Foundational, so we can talk about the major players, how the money flows, because that's how the data often flows, how the incentives are aligned or not aligned, just very high level systems overview. And then next week is when we'll really start diving into 2 major types of data in healthcare, the EHR or clinical data, and claims data. Mary will cover a lot of the EHR and clinical data with her weeks 3 through 6. And then I'm going to pick up in week 7 and we'll go really deeper into the claims data side. But those are the 2 primary data types in healthcare, at least for getting started. And so we're really going to go deep on that. Week 3, Mary will introduce you all to the USCDI core standards, core tenets and foundations of interoperability. That'll be a lot of different like code sets and some regulation, things like that. She'll show you how and where to find all of this stuff and what it means. And then starting in week 4, starting to dig really deep into some hands-on activities and learning around HL7, going into weeks 5 and 6 in fires, more modern API and advanced use cases. In week 7, I'll come back and I'll pick back up on the so once you have zoomed in kind of clinically and zoomed into the clinical data, I'm going to come back in. We're going to zoom back out to some of the population health. And I'll define that and we'll talk all about what it means. Value-based care, things like quality measures and risk stratifications, all the stuff that a lot of health plans and payers are using to manage populations in tandem with claims data and the EHR data. And then weeks 8, we'll talk about digital health, social determinants of health, and health equity. We'll talk about evaluation frameworks and a little bit about how digital health is transforming the future of healthcare and what that means as you all go out into the world and start thinking about launching digital health or tech-enabled interventions. And then week 9, not my favorite topic, just it's not the most exciting, but some of the privacy and security standards and things like that. But week 9 is also where we'll present out our capstone projects for those of you who choose to embark on that. All right, so I think we'll take a little bit of a break here, and then we'll come back. I'll talk a little bit about the times, and then we'll dive in. So why don't we take maybe a 10-minute break, come back at 4 o'clock, and we'll keep on going. Anyone have any questions in the meantime? All right, I'll see you back here at 4 o'clock. Wow. Meatball. All right, as folks are back, if you could turn your camera on or just pop in the chat and let me know. But it looks like we have some folks coming back already. All right. So real quick, because I want this to frame the lecture content about the ecosystem. I do want to talk briefly about the CAHIMS. It sounds like, at least I know Abdul Wakil, sounds like you're interested in the CAHIMS certification. If you are and I know not all of you may take this, but if you are interested in possibly doing it, let me know up front. Shoot me an email or when we chat one-on-one, or even just pop it in the chat here. And what I'll do is when we meet one-on-one, we'll talk a little bit in more detail. What we're going to talk about here, we'll prepare you for it. There is some additional learning and additional learning resources that you'll need for that, and we may have some funding available through the college if you do plan on it, but I'll just need to know in advance. So keep me posted. But for those of you who are interested, I just want to show you these real quick because you'll want to follow along with some of these resources I posted as we go. While we will touch on some of the topics here in class, we're not going to go as deeply into all the topics, so I've provided some additional resources, and Abdul Wakil for the book. That may be where it comes in, but it'll be up to you depending on how much additional you feel you need, especially given your background with your MHA and all that stuff. So, all right. So in Brightspace, first of all, you should all have access to this. If you don't, let me know ASAP. Allegedly, they got all of the issues straightened out today. But if you go to the welcome, start here. And I got a few links for you. I'll be, again, updating these. This is where you can find your capstone worksheet that we'll talk through at the end of class today. But down here, there's some additional information about the certification. So just the website page. This competency gap, it's a nice table that shows you all of the key topics that are in the exam. So you can kind of look at that and kind of do a self-assessment of where you feel you might need to do some additional learning or where you feel pretty good. There's a learning plan. This is just kind of a high level like outline of kind of the sequencing and the timing and the study sequencing that you might want to do. But this review course, additional topics, this is like a 100 or 200 slide deck that goes into some of those competencies from the competency assessment. I don't know, again, it'll be bespoke to how your background and how comfortable you are with some of those topics, but that review course really gives you a good idea of some of the topics and the detail in those I lost my words in those sections. And then just kind of a general timeline to follow along with. So look at these. I'll just orient everybody I'll encourage you to go look at these, and then when we meet, we can talk about it a little bit more. I would encourage you, though, as we're going through class and lectures, just kind of maybe follow along in this review course. This will kind of augment some of the stuff that we won't have time to go into. And some of it's a little bit basic, and I didn't want to use our time for that. So, but yeah, I would point you there first, and then let's talk a little bit more. All right, without further ado, let's go ahead and jump in to our actual topic, the U.S. healthcare system. And thank you, Paras, for pointing out that everything I'm going to talk about today is very much U.S. specific. I think we've created a kind of a monster, but again, that creates some opportunity, but I think it's also just really entangled and challenging. And so I often think about how some of our stuff translates, outside of the U.S. and how it doesn't. But yeah, we'll definitely be focusing on U.S. healthcare, which has a lot of U.S.-based policy regulation and incentives and reimbursement and all of the stuff that we've constructed here because we do not have a national health services or universal payer or universal healthcare like some of the other, other nations do. Our objectives for today, for week one really as a whole, I really want everyone to understand the system players and how they all come together, specifically what we call the value chain, how the money flows, because that's, as I mentioned before, where the data usually flows. We're going to do some connecting of the dollars to the data. This is a little bit of week one and week two. We're going to trace that through through the system a little bit at a high level, and this really just is going to set the stage for everything else for our future classes. So just, healthcare by the numbers. I mean, here in New Mexico, healthcare is our largest industry by the number of employees. So it's the number one we have the most employees in the state by volume. And we are the #2 industry if you're considering it from a revenue perspective, only second to oil and gas. So that just gives you an idea of the magnitude. So that's New Mexico. Nationwide, that's 18% of the entire GDP, 4 trillion of annual spending. The numbers are staggering of just the sheer number of organizations and stakeholders that are in that. So even just a sliver of the stakeholders, the healthcare insurers, which are sometimes called health plans. These are like our Blue Cross Blue Shields of the world, Humana's, stuff like that. More than 900 across the nation. Hospitals, our Presbyterians, the UNM hospitals of the world, more than 6,000. And this is just hospital type systems. This doesn't even start to get into like clinics and federally qualified health centers and ancillary providers and all kinds of other clinical providers. And then just the number of workers, healthcare workers, huge, 20 million. A huge proportion of that obviously is clinical frontline staff, but a very large portion, and where a lot of the dollars go, are the administrative staff. It takes a lot of administrative roles to keep hospitals and healthcare running. So it's just a huge opportunity. The key issues are, for me, cost, quality, are people having good health outcomes when they're going to the hospital and things like that, patient safety, kind of the bread and butter that you think of when you think of healthcare. But for me, the reason that these issues are important is, aside from wanting to have a good health system, these are all the areas that we're starting to see a lot more innovation come out, and digital technology. So it's a little bit of it's a double-edged sword, because a lot of times adding in technology and new tools and systems actually increases cost under the guise of decreasing cost. And so for me, it's always a fine line to think about, how do we innovate without adding to the bloat and adding to the, the tanglement, if you will, of what already exists. So I wanted to pose this here for you all just as kind of key topics, but this is really where we're starting to see a lot more attention on technology, because I think that we've been doing things the same way for a long time, and we haven't seen a material change in outcomes or decreases in costs and stuff like that. And so as you all go into the world, I'm always thinking about, how can we do this in a way that's actually going to make a difference and not just add to the problem. But these are kind of some of the areas of where we see that. And then you may hear the quintuple aim or the quadruple aim. I think this has undergone a number of changes, but similar to the previous slide, you'll hear people talking about this a lot. If a new intervention or innovation or technology tool or whatever it may be doesn't address at least one of these things, it's usually not going to get a lot of traction in the system. And so everything always should or tries to tie back to one of these aims of this quadruple aim, now quintuple aim. So it's always patient experience, population health improvements, care team well-being. So the care teams, like the clinical teams, because they're burnt out and all of that. Now they've added advancing health equity, which I love. We'll talk more about health equity and what that means in practice in week 8 or 9. And again, lowering cost of care. So it's interesting to me that these are all the things that we've been striving to, but it seems like we've actually been kind of working in the opposite direction of a lot of these things. But that's the quintuple aim, and we'll talk a little bit more about it. And I kind of want to set the stage a little bit about what innovation means to me. Depending on who you're talking to and where they sit in the big healthcare ecosystem that we're going to talk through here, it can mean something very, very different. So innovation very broadly, just at a basic level, new concepts, new services or products intended to improve, treatment, diagnosis, prevention, delivery, costs, all the things that I mentioned. But more specifically, I think innovation is thrown around as a very broad term to just mean like something new and flashy. And one thing that I will push us to think a little bit more about is, like, is this truly innovative and new and different? Is it different because of how we're doing it or how we're implementing it? Is it different because of we're actually talking to patients and communities first before we're implementing? Like, that's very innovative. Like, what's innovative about what we're doing? Because it's not just a new tool. If you talk to a healthcare executive, a lot of times they'll say that they're doing a lot of innovative things, and then when you start to peel the onion, it's really just like a new program or service that's really just not something very different. Oh, Zoom's not responding. Did I pause?
We can
Can
hear
you still
you.
hear me?
Uh,
Okay.
No,
Zoom
you're
might,
good.
okay, Zoom might crash on me here, but so that's like a healthcare system, and then there's a lot of conversation right now coming out about what they're calling like performative innovation, because innovation has become a buzzword to attract funding and to attract, flash and all this stuff. So throughout this course, I want us to think about, what does it mean to you? It could mean something different. I'll tell you a little bit about how I think about it, but just know that if you're throwing that out, it could mean something different everywhere. When you're talking to researchers and academics and things like that, when they hear innovation, a lot of times to them that means moving a technology or something that they've developed inside of the lab or inside of the research institution out and commercializing it. They think of that as innovation. So we can dive a little bit more for folks who are interested kind of in this health innovation specifically. To me, it's really new and novel tools and technology that are going to shift paradigms. I'm really interested personally in things that are going to include people who have not been traditionally included, how we implement them and how we design them in a inclusive, or what I'd call in my academic work, a participatory way. And I'm really interested not just in another new innovative tool that's going to increase more revenues, for a hospital. I'm really interested in things that are going to like maybe move healthcare outside of the health system and move it more into community or patients' hands. Like those, to me, that's what I'm most interested. So everything you hear from me is going to come kind of from that equity paradigm shift, sort of participatory perspective. That's the lens and the bias that I bring. Okay. I want to give a little bit of a high level. I better pull up my chat in case I'm missing anything. So just in terms of healthcare, I kind of was joking that I'm biased. I think it's the most complex industry, but really, I mean, even just the technology systems within healthcare do not talk to one another. So I mentioned a couple even just in my overview of what we're going to learn about. EHR systems and clinical systems versus claims system, which is how healthcare providers and care delivery providers get paid. There's lots of things in the public health domain, and Graham and Susan probably work with, like, there's registries of patients and immunizations and births and deaths and all kinds of different systems there. Then there's a whole slew and a whole ecosystem of patient applications. You may hear me say something like digital health. That could be like an app, or just some kind of digital or technology enabled tool. There's also a whole slew of technology vendors in healthcare, and all of these things like very rarely talk to one another. Mary will talk more about interoperability, and that's what that means, is bringing all this together, but it's highly, highly fragmented, which I think is why courses like this are super important. So there's the technology component. Now there's also the payment or the funding and delivery component. So as I mentioned, we don't have a universal payer type system, universal healthcare. There's 900 plus health plans, or again, Blue Cross, Blue Shields of the world, that are paying for care. They all have different requirements. They all have different types of paperwork and documentation that's required. None of them, there's no continuity if patients move from one to another. There's lots of manual processes to, exchange data back and forth and all of this stuff. There's private plans, there's public plans like Medicare and Medicaid. And there's many different ways or methods or modes of reimbursement, which means how a provider, a healthcare provider, or clinician or doctor gets paid. So when you bring all of this together and you couple it with the fragmented technology, you can just see how it just starts to kind of like compound and exacerbate on itself. In terms of the complexity. And if you love a good complex problem like I do, and like some of you all mentioned, you're going to just be intrigued by this. And then I think really at the crux of it, there's what you'll hear commonly in the field is misaligned incentives. That's a pretty common trope, I guess. There's this whole, how can I say this? Healthcare traditionally is paid, and we'll go much deeper on this, but what's called a fee-for-service model. That means you do it, a doctor performs a service, gets paid for the service, and the more services the doctor performs, the more they would get paid because they do more. It's volume-based, right? Fee-for-service, volume-based. You can see where that can add a lot to increasing costs, and where potentially it could provide a disincentive for healthcare healthcare providers say to maybe want to lower volume and keep people out of the hospital, right? It just the nature of the way that the system is set up creates an immediate tension between sustainability and revenue and healthcare and preventative care. And so that's our traditional fee-for-service model. We see that on the left. There's this movement, and if you all have been kind of like healthcare or healthcare ancillary, you might hear value-based care coming in and out of popularity. It was a little bit more popular before health equity took over. Now it's coming back again. But value-based care is kind of this mental shift or model shift to where we're trying now, instead of incentivizing you to by volume and how many services you provide, we're trying to say, okay, if you provide better service or more high quality, and you don't do things that aren't necessary, again, what they would call high value, then we'll pay you more for the outcomes, and we'll pay you more for being a higher quality or higher. And so that's ideally supposed to incentivize quality. But you can imagine that it's not so easy for, a provider, which I will just kind of use colloquially to talk about a doctor, a hospital, anyone, any care delivery or care provider, I'll call them a provider. It's kind of hard to get them to sign up for, okay, well, potentially I'll make less money if my quality outcomes are poorer. I could potentially make what they call upside. I could make more money if I do well in my quality outcomes. But you can see that, again, it just creates this natural tension. And I think this is one huge reason we've not really been able to move out of this whole fee-for-service mindset. Here in New Mexico, what we see, this is, and I'm kind of oversimplifying it too. There's a lot of hard things that come with moving to a value-based care arrangement, because you need a lot of more sophisticated technology. You need systems that talk to each other better so that you can manage care better. You could be more proactive. There's a whole financial readiness, because, smaller providers, they don't always have the means financially to potentially take some downside or potentially lose some money so that they could get into some of these arrangements where they could possibly get more upside. So there's a lot of complications there. But here in New Mexico, what we see is we do see some value-based care arrangements. A lot of them which means, a Blue Cross will go to a healthcare provider and say, okay, we'll pay you if you do really well on these quality scores, we'll pay you an incentive, a bonus. So we see more of a bonus structure rather than we don't see as many of the ones where they're taking that, what they call the downside risk, or possibly making less money if they don't perform. So that's kind of the stage of where we're at here, I would say. I'm just going to check and make sure no one's got me in the chat. Cool. Okay. And then healthcare in general, highly regulated. We're not the only highly regulated industry. Oh, Trevina, go ahead.
So just a quick question for your previous slide about the complexity of fee-based versus the value-based. I may be jumping the gun, but I just want to kind of ground it in what I understand so far. Particularly for this slide, how does this relate to like those MCO carve-outs? Like how does the incentive, because I thought that was value-based care. So like if you have a carve-out that's maybe doing what are some that I've worked with? Maybe they're just doing advanced diabetes or something. And so how does that work? Like, do they do value-based care? Because they are clearly tied to the outcomes, right?
Mm-hmm. And do you want to explain what you've seen in terms of what the carve-out might mean for folks who may not have experience with that, or how you've perceived of it?
I can fumble through it. I'm not an expert at all. I just know that, for instance, when I was in tech sales, one of my clients, like an end user that I could sell the technology to, was this carve-out service. And what they did tied them to, it almost sounded like they had to have a certain level of outcomes in order to keep that contract with whatever the state or the Medicaid provider was. A lot of times it was for, we had some that were for behavioral health. We had carve-outs for behavioral health. We had carve-outs for kidney failure, advanced kidney failure. And so I just was trying to figure out, I don't know where that fits into this, or if it fits into this. And I know my explanation wasn't very clear, and I'm sorry.
No, that was great. No, that was great. I'll add a little bit of context. So sometimes So first I'll say, like everything in healthcare, there's many, many, many different flavors of almost everything that we'll talk about here today. So what you've described very well can fall into the value-based care, like overarching bucket. There's many different types where you may say, okay, I am a primary care provider and I'm interested in doing a diabetes program because we do diabetes really well and we manage our patients really well. And so we'll make a carve out where it's just a program for that. And we'll only take on some additional risk or maybe get a bonus or whatever just for the diabetes stuff, and everything else you're paying us as fee for service. There's and every which way slice in between. So yes, it does totally fit into that. I would guess, without knowing the details, it probably is a sort of value-based type of an arrangement. There's also some providers or even vendors and services out there that are like highly specialized. For instance, we have one here in New Mexico that focuses only on cardiac health. And they have a whole network of cardiac care and cardiac providers, and they may just enter into a specific arrangement either with a provider or with a health plan directly and say, we'll just manage cardio. Like that's our thing. So many ways, shapes, and forms. So it definitely does fit in here. My guess is there's probably some overlapping ways. Does that help?
It does. Thank you.
Of course. Great questions though. And if you guys have any, you want to pop them in, we can chat and go off and kind of off-road on some of this stuff too. Because I know there's a lot of context. Cool. All right. So the regulation, I was just saying, someone mentioned earlier, like HIPAA, we'll learn about HIPAA in week 9. It's arguably the most, important privacy and regulation framework in healthcare. That's to protect patient privacy. There's laws around what kind of data you can share. It can be very restrictive. I think a lot of times, and then there's many other regulations and policies and things that govern healthcare. Again, we're not the only highly regulated industry. You can think of like the financial services and national security and stuff like that. But I do think that we have, again, tying into these incentives, the regulation in our industry can be so, I don't want to say overbearing because a lot of it's really necessary, but so stringent. We have FDA that needs to approve a lot of things before they can even go and touch a patient. You got these long clinical trials that are needed before something can even see the light of day. All of this, and we'll talk a little bit more about regulation in week 9. But all of this, the reason I wanted to bring it up was because to me, I think a lot of this can stymie innovation. I'm not purely like we need to do away with regulation. It's very important because there's lives on the line. I mean, this is very important stuff and it's life or death, but it's very hard to innovate in healthcare. And so, we can't, when I come in and I'm like, we can innovate and we can think about what we can do better and we can do it differently. Well, yes, within reason. And so I'm putting this here just to remind everybody, to just challenge us to think throughout. How do we start to chip away at what we can and still innovate within the confines of what we're able to do? Because to me, I think that's how we're going to end up transforming the system, smaller bites. So that's just kind of my thing, is that, again, the tensions that we're seeing between regulation and innovation. So we've named a number of really key tensions in healthcare that make it really exciting and interesting and infinitely, exciting to work in, but also the real, some of the rubber meets the road reasons why we don't just, try something completely out of left field and why that can't happen always. Someone told me once, and this might resonate with some of you, that innovation in healthcare can even be a process improvement. And I do believe that to be true. Like that could still be very innovative within some organizations. I'm speaking from a New Mexico lens as well, where, we don't tend to be as risk forward here. I see in our healthcare system, I think a lot of New Mexico, we like to, as healthcare, we like to look and say, well, what's Texas doing or what's California doing? Because they're more advanced and they're more sophisticated, or they have more resources and money. And so I think a lot of times in New Mexico too, there's this extra layer of like, let's wait and see what's working elsewhere. And then there's also this layer of like, we're really protective of our people. And I think we need to be. We have really unique constraints and really unique, needs and stuff like that. And so I'm always thinking about how that comes together. Systems thinking, again, all of this is just to kind of frame how we're thinking about innovation and change kind of going forward. I mentioned earlier, I'm a big systems thinker. It sounds like many of you are as well. I think the age-old adage in healthcare is like, it's the payment system or who's to blame, someone like the doctor didn't do something. Those are all true. But to me, when I start thinking about where are we going to innovate, where are we really going to do different, I like to zoom out and like think of it from a systems thinking perspective. And it's more like, what systems cause this, and how do we start to kind of change those from within? Because I think the blame doesn't go very far. There's many multiple failure points along the way. I just think that this kind of systems, collaborative, cross system thinking is really, I think, the future of healthcare, because things are becoming so intertwined these days. All right. Let's talk a little bit about, so we kind of talked this kind of setting the stage for sort of what we're working with, if you will. And I'm going to start talking through some of the ecosystem players. Having worked in healthcare for many years, I forget often that I use a lot of terms and lingo and acronyms and all kinds of stuff that just do not even occur to me anymore as being not common terms. So please keep me honest if I say something that you don't understand what it means, even something like provider. What did I mean by that? Please pop it in the chat. Everyone here is pretty much new to healthcare, and I just tend to that happens once you've been in the field for so long. So. All right, so here's our big ecosystem. I like this because I thought it kind of, I mean, there's still more. It's a huge thing, but I think this kind of captured like our biggest sectors or stakeholder groups, if you will. I would argue that probably we should put patients and consumers sort of in the middle of this ecosystem, but it kind of has it here over to the top right. And then I think it's sort of going kind of in a more of a granular all the way to like a maybe bigger, but so just kind of going around, we have our patients and our healthcare consumers. Of course, we have our healthcare professionals. These are all of our frontline staff, doctors, nurses. We have tech, like radiology techs and all kinds of stuff. These are folks who are working there doing clinical work. And then then going down to the middle right here, healthcare providers. I mentioned this earlier. I use providers very colloquially to talk about really anyone who's providing healthcare, whether that's the healthcare professional and a clinician, or a clinic, or a group of clinics, or a system of clinics, or a health system, which is like a Presbyterian. So I've been using that term very, very broadly, but there's many layers in between that, all the way from our individual provider to like an independent provider, small group, to a clinic, to like a group of clinics, one single hospital or a group of hospitals. We call that like a health system, all the way up to like integrated delivery networks, which is truly a Presbyterian healthcare services, probably the only one here in the state, or one of the few that has hospitals, provider, medical group, and even a health plan all sitting within it. So many, many different layers on the healthcare delivery side. And then moving kind of clockwise here, going down to payers. You'll hear me say payers a lot. You may also hear me say health plan, or you may hear me say managed care. At the end of the day, these are all similar in concept. Basically, these are the Blue Cross Blue Shields of the world, the Humanas, the Cignas. These are the ones, the insurance companies, basically. There's nuance there. Managed care is like specific to like a Medicaid or Medicare, or a way to manage the insurance. But really, when you hear me say payers or health plan, I'm talking about these insurance groups, the ones who are paying providers for their care. We'll dive a lot more into payers and how these things interact in a future week when we talk about the money flows and how the data flows. And then, of course, we have government. I mean, government is a huge stakeholder, for better or for worse, in healthcare. It's also, so you may hear me talk about CMS, the Center for Medicaid, Medicare Services. They kind of flow up through the Health and Human Services arm in our federal government. Not only are there many, many departments there that set regulation, things like TEFCA and all this stuff, like ONC will set, that Mary will talk a little bit about, but we also have policy, reimbursement, how things are paid for, what's paid for, how it needs to be coded. I mean, they set all of these rules and regulations that then everyone underneath is beholden to. So that's like a huge role of CMS, is just administering and managing, particularly the Medicaid and Medicare services, but that drives almost every other type of service. So for instance, if you don't have Medicare or Medicaid and you have insurance just through like your employer, like many of us do, a lot of the times the guidelines and the way that they operate will be very similar to like the Medicare guidelines. It just, whatever CMS sets sort of at that level is kind of just ends up changing the whole industry. So that's kind of unique, but the also unique thing about the government and specifically CMS and Medicare is that's actually also the largest payer in the nation because they, by running Medicare, they actually also operate as a payer because they're paying, again, as I mentioned, paying for healthcare services for folks who are in these Medicare programs. So, I mean, it's just a behemoth, and understanding what their priorities are, their rules, how they do things, and all of that. I mean, when they say jump the whole industry, I mean, you hear waves through the whole industry. So it is very important. And then, of course, we have some folks who are equally, in my opinion, as important to the ecosystem, but sometimes, much to my chagrin, don't get like grouped into the healthcare ecosystem because they're sort of seen as like external too. But to me, they're critically integral as much as a healthcare provider. These are things like our technology players, technology vendors. Of course, there's pros and cons, and everyone loves to hate on like Epic, the largest health record, electronic health record provider in the nation. But without these technology and service providers and vendors and who all have their own niche, like in my opinion, I don't think healthcare would even operate or run remotely efficiently. And so to me, these folks are key and integral into the ecosystem. There's also a lot of opportunity for folks like you all, if you're thinking about getting into healthcare. That may not actually look like working for a Blue Cross or a Presbyterian. It could actually look like working for like a healthcare software company or a Velatura or something like that, or HIE. I mean, these are where these folks really, and that's a huge, huge area of opportunity and a huge area to innovate. I think these folks are really going to drive sort of what that innovation and all that digital health transformation looks like. Of course, we have pharma and med tech. These are our devices. A lot of time, I think they probably group these two together because these are the ones that a lot of time have to have that FDA approval. Pharmaceuticals, we could talk for hours about all of that stuff, but they're kind of sitting outward there. And then one that I don't see often included, and one of the reasons I liked this ecosystem map is really these startups and academia. Startups could also fall maybe into some of these like high tech players or into this part of the ecosystem, but what we're starting to see and what I'm really interested in is and bringing a little bit more of this to New Mexico is these startups can move really quickly, and they have these like really novel like AI solutions, and they can move faster in technology and methods than maybe healthcare proper can. So I'm really interested to see like how can we bring more of that thinking with it into this big behemoth healthcare system, again, in a way that's responsible and in a way that can fit within the current regulation and stuff. But I think we're going to see a lot of innovation coming out of these startups. And startups can be anything from a very small, early stage, entrepreneur with an idea, all the way to like later stage growth companies that are kind of verging into bigger, larger, sustainable companies. And so when you say startup, it can even be a little bit of a misnomer. This can be a technology company or service provider of many different sizes. And I think there's a lot of opportunity there. And the same with academia. We have a ton of researchers in our university who are researching like groundbreaking like treatments and new methods and all this stuff. And I think there's not a great bridge to get some of that stuff out of academia and like into healthcare. I saw some number where it was very dismal, like less than 20% of like evidence and research that comes out of academia actually makes its way into how healthcare practices. So again, just another huge area of opportunity when you zoom out systemically, like how do we connect all of these? This is what we're working with here. And again, I know this is a lot. I'll post all of this. I don't expect everyone to memorize all of this. It takes a while, but I just wanted to expose you sort of to the broad network that we're working within. All right. Now, that was kind of talking through the players. This is a different way of looking at the same sort of information, but starting here on the bottom right with our patients, you kind of see how everything's connected. Our patients see physicians or hospitals or integrated network delivery networks, all the types of providers that I talked about. So that's that band in black. Integrated networks, hospitals, long-term care facilities, outpatients, and so on and so forth. So that's sort of the first line. And then, as I mentioned, you have this next band of heavy hitters that are the payers. That's that middle gray line there. So you see the payer in the middle. And again, we use that term very broadly. A lot of times, it's interesting here, people will also group employer groups in this payer category because if you're not on Medicare or Medicaid and you are paying, insurance premiums, like I said, through an employer, a lot of us have employer-sponsored health plans. The money goes into our employer group, and typically they'll end up contracting with like a Blue Cross or something to administer it. But they are a lot of times employer groups are also managing populations of patients and people, much like a payer who's managing Medicaid population maybe. So employer groups also kind of operate that way. And then we have our regulatory agency there, which probably is CMS, which is probably why it's that color, yellow. And they've kind of lumped them here into the payer group, as I mentioned, because they are one of the largest payers, but they also influence everything else. And then I just kind of got even more additional stakeholders up here. We've got all of our public health friends who are doing tons of like preventative stuff out in the communities, prevention, education, health promotion, all kinds of stuff, a lot more tend to be a lot more like community and outward facing focus versus like healthcare, where we're kind of like looking inward within the four walls of our hospital or whatever. We have community groups and community agencies that are doing services, bio, pharma, digital health tools, and vendors, kind of some of those other ancillary stakeholders that I mentioned. I'm off there to the left. I'll stop here. Does anyone have any questions about any of this stuff? I know that was kind of a big high level ecosystem view. Yeah. Highly complex industry, which is one of the reasons I love it. I think I'm like a glutton for punishment or something. Okay. So I want to shift a little. We'll talk a little bit about some of the specifics. We started very high level. I wanted to talk a little bit about some of the details of what some of these groups do. I really want to highlight public health and community partners. I just don't think that they're often brought into this ecosystem enough, but there's so much that they do that goes unrecognized. And so I just wanted to give everyone kind of a perspective of that. So our state and local health departments, they're doing a ton of like disease surveillance. When a new outbreak of something like infectious disease happens, like they are all over it. They manage tons of data. In fact, if you go to our Department of Health website, I actually linked it as one of our resources for our capstone. Tons of data about New Mexico and the health of New Mexico and different indicators going on in New Mexico. So doing tons of like epidemiological studies and all kinds of stuff. Obviously, like when COVID hit, there was a huge outbreak response. So they're just really integral to the system. And I would love to see us like working, closer together. Because I think that as healthcare moves out, my goal, moving it out of the healthcare system and like more into the hands of patients and communities, I would just like to see that bridge a little bit more. But I just don't think that they get a lot of credit publicly there a lot of the time.
Thanks for the love.
What was that, Susan? Yeah, you're welcome. It's like quiet, thankless work, right? Sometimes. And you see in the bottom here, Susan and Graham, we've kind of mentioned that increasingly you all are getting connected with like our healthcare providers and working together to manage health and understand health in New Mexico. So I think that's very important. And then this middle group, another under recognized, maybe potentially undervalued community organizations. Sometimes you might hear them called like community-based organizations or CBOs. There's been a push in recent years to, as healthcare has realized that a lot of things that influence healthcare actually have nothing to do with healthcare once you're in the healthcare system. It's like all these social factors that I talked about, transportation, poverty, education, all the things outside that we call the social determinants of health. And we've had these community-based, these CBOs or these community organizations out there in the community, like doing all this great work that is so integral to healthcare. Providing services like food insecurity and food delivery, housing and transportation. But we're also starting to see them get looped more into the healthcare system in a more meaningful way. So, for example, because in the past they kind of sat on the sidelines as like, okay, yeah, like they're out there in the community doing like a food, food pantry or whatever every week or whatever. Well, now what we're starting to see is like real investment where healthcare itself in some cases is like say, hey, like we'll pay you community-based organization as a partner to provide these food services or to provide this transportation service for a patient. It's not a healthcare service, and in some cases it may not even be a medically related social need. But because they're starting to recognize the impact that all of that stuff has, so if you can't have transportation, you're not going to make it to your appointment. So we're starting to see a lot more of that collaboration. Our state is also investing, our state Medicaid agency, which is called the Healthcare Authority or the HCA. They're actually investing in a new technology system called a closed loop referral system. And it's all about enabling a healthcare provider to provide a referral to some sort of community or social organization for non-medical related social needs. So it's like similar to like if they would refer you to like a dermatologist for something, now they could refer you to like the food pantry or whatever it was. And the closed loop referral system, this technology system that they're actually implementing, kind of tracks like are services available, where they're being referred, did the patient actually go and like use the service, what were some of the outcomes, and it's trying to link all these things together. I don't know what vendor they actually decided on or if they ever have announced that yet. I know it's been underway. Someone else might know here, but it's interesting to me because you see the intersection of technology with this social determinants of health kind of concept. And we are starting to see, again, this ecosystem just grow in terms of complexity, but also in terms of services. I'm not going to walk through all this, you all. If you're interested in the regulation, I'll just put it out there. I'm not as much of a regulatory person. Some people really get into like policy and all this stuff. It's super important. Like I said, it drives seismic shifts in our healthcare industry. I'm really like interested in what we do with it. But here's just some high level regulators or big players in the industry. You can kind of look, through all these and we'll talk a little bit more about them throughout the course. Of course, I mentioned CMS. The CDC is a huge one. Our public health friends work and deal with them a lot. FDA, NCQA, who sets standards. So we'll talk a little bit more about these kind of in the latter half of the course. What else is kind of tweaking out here? Okay. I talked a little bit about payers and how they control the purse strings, as you see here. I just wanted to, again, reiterate that there's many different flavors of this. So commercial health plans, that's like employer group insurers. Managed care organizations here in New Mexico, typically when you're talking about a managed care organization, they're usually talking about a Medicaid managed care, of which we have 3. There's Blue Cross Blue Shield, United Healthcare, Molina. Oh, sorry, there's 4. And Presbyterian, of course, is our largest. So those are our 4 managed care organizations. Of course, those organizations also probably provide what we call commercial plans. But a lot of times, because New Mexico is like over 40% Medicaid, which is one of the highest in the nations, we have a ton of managed care activity. The way that managed care works and operates is a very like population health improvement model. We'll talk a lot more about that and the incentives and the measures and what all that means in week 8 and beyond, because that has been kind of a core of my work and kind of how the state sort of approaches healthcare in general. And then we'll have like our public programs, again, Medicare, Medicaid, but these are also things like veterans who are getting their insurance through the VA or through TRICARE. These are basically government run. They're not quite universal healthcare because a lot of them have to, have certain requirements and things to be enrolled. But they are generally government administered. The government may opt to sort of dole out some of the money to like a private entity like a Humana or a Blue Cross to manage it, and that's where we get into our managed care. But at the end of the day, it kind of comes up to our government public programs. And then, as I mentioned on the bottom right here, we don't have as many of these in New Mexico. So self-insured employers. So these are huge employer groups, like if any of you worked or have ever worked in like the education system or for UNM, they all contribute to the education board. it covers, like all the educators in the state. It's such a big group of people and they have so much money in those benefit plans that they're actually able to like say, hey, instead of like the managed care organization managing our costs and our healthcare and our population health, we'll manage it ourselves. We'll self-insure. We cover it out of our pocket when something happens. They kind of operate in this way too. So I just kind of wanted to drill into this a little bit more because there's lots of different flavors. But at the end of the day, you can think of these payers as like they have the money because it was paid into them through taxes or employee premiums or whatever, or the government gave them, for Medicaid payments, whatever it is. They have the money, and then they're the ones that are then paying our providers, as these services are occurring. That's really the crux of it. There's lots of things that happen there and things we'll talk about more in week 8 and beyond of how those work, but that's really the purse strings there. I know a lot of you have mentioned some exposure to healthcare and specifically from like the patient side and maybe the provider side. I think payers get a really bad rap a lot of the time, for legitimately and not, I guess, but I think that to me, and also because I've worked in payers a lot, it feels like a lot of people who are trying to do the right thing. There's a lot of policy and bureaucracy, but I also think that because payers have all the money, like to me, I also see them as a big opportunity where they actually could like really move the needle in a lot of ways. And so for me, they're actually kind of more of a target for me for some of our innovation opportunities. And then we talked about providers. As I mentioned, there's lots and lots of different layers. I'm not going to go through all of these, but if you have any questions about any of the specifics of these different, I already talked about some of the different levels and stuff. If in your work or in your capstone or anything, if you start coming across anything like this and you want to talk through the differences or how this interacts, just let me know. I'm happy to talk through any of this stuff and unpeel it a little bit more. And then this, it's both confusing but also encouraging. The reason I wanted to show this, like this is really kind of different domains of health IT, kind of through the perspective of like a large health system or a hospital, like a Presbyterian. You can see all the different little areas where there's technology, but there's also like, and like all of these have their own little niche and like their own, systems that a lot of like incumbent systems that a lot of people use. And so like if you learn one, care management system at Presbyterian, a lot of times that makes you transferable to a lot of other systems because a lot of them are using the same kinds of stuff. There's different areas that you could focus on. So if you're more into like, that's great, but I'm not really into like clinical stuff so much, but I'm really interested in like financial incentives and all this stuff. Well, you might work entirely in revenue cycle. There's lots of, or cost of care here, revenue cycle, there's just lots of different areas that depending on your own interests and skill sets you could be, and you could really specialize. Like if you said, you know what, I'm really interested in revenue cycle, and we'll talk a little bit more later about when the EHR and claims data course about kind of what that consists of. But if you end up saying, I'm interested in the finance part of it, some people will only work as like revenue cycle analysts, like for the rest of their career and just like all revenue cycle. Others have focused exclusively on supply chain and logistics. And a lot of all of this has data and technology and workflows and all kinds of stuff folded in. So while it looks kind of overwhelming, no one usually works across all of this stuff. Like usually folks are kind of, once you get in there and you start kind of getting your niche and your experience, a lot of folks settle in to something and you can still go really deep. So if you're interested, if anything here like looks, appealing to you, let's talk about it. Again, I'm, happy to help kind of think through what areas you might like based on your background.
Could I ask a quick question on that one back there? What do you consider like the difference between like integration and analytics and information technology?
Let's see, where are we seeing those?
Over on this side, like the 5 main squares.
Oh, human resources, fine. Okay, so that's a great question. I'm glad you asked actually. When you look at the HIMSS and the CAHIMSS stuff, you'll see what I think is kind of a very traditional like health IT perspective. So to me, that's like a lot of the systems. A lot of times if you're like the CIO or VP IT or whatever, you're also like managing like security and cybersecurity. Sometimes there's like coding and documentation and informatics that falls under that. it's a lot of these like technology systems, cloud compute and cloud storage, and how much money is that costing us, and how are we using it? I'm speaking very generally because it could be set up very differently depending on like every organization. Everything is very different. So I'm speaking very generally, and actually I'd like to hear Mary's thoughts too. But the way that I kind of view them is, so these are like these systems. A lot of times it's like Epic Uptime and Epic integration implementations and stuff like that. What I think has happened personally in healthcare is like, because of all the things I've been talking about and belaboring about the complexity and the number of solutions and all of this stuff, and the mass amount of data that started to come out of all of this, I think what I'm starting to see sort of is this natural like segmentation into this sort of what they're calling here integration and analytics. I don't know if I call it that, but um, how are we using that data? What are we doing? Now we're needing like data scientists and people who can like develop apps and like integrate all this data together. Like those, to me, those have been very somewhat different skill sets, or maybe expanded upon kind of what traditional health IT kind of always has done. I don't know. Mary, do you see it differently if you're still here with us?
Stephanie, great lecture, great insights into that question. In my experience and how I think about that difference between those two boxes, the integration and analytics and the information technology, starting from the bottom, the information technology. Often in healthcare, we make technology choices that are not specific to healthcare. We choose the internet, we choose a cloud computing service. You have to make choices about how you engineer your system, what types of computer systems, what types of technology you choose. The integration and the analytics takes you into the space of all the data that we utilize in healthcare. And there's a whole career path called informatics, which is actually that little spot between the two, and why things like the CAHIM certification exists. How do you bridge from running your healthcare data, doing a public health report for analytics, the choices that are made about that technology that you're running your systems on may impact your data in various ways, or your ability to run an analytic algorithm, either efficiently or not efficiently. So very, very good question and a great lecture. Stephanie really brought a lot of insights as to the complexities of the health domain.
Yeah, thanks so much for those great answers. Thank you.
Does that help, Susan? Kind of contextual. It's a little, yeah, and Mary, you may attest, like it could be different. Like sometimes data and analytics might sit under IT. Other times data and analytics might actually sit under finance. So it's not quite a one and done, but
Yep. Thank you.
sure. All right. Good question though. Keep them coming if there's anything you want to dig in. Okay. So I think we all know that patients and consumers should be the center of everything. I would maybe argue that maybe they're not always, but the reason this is important to me right now is because I think the patients are really going to drive some pressures and kind of what we see over the next decade or two. And patients, I mean, you can put yourself in a patient perspective because we're all patients and navigators of the system. We want to get appointments when we need them. We want to have access. We want to be respected, and we want to be treated in ways that match our background and our values and our culture. We want to be able to afford health insurance, and we want to understand our own health. And I think there's nothing groundbreaking there, I don't think. But yeah, I think these are some of the biggest things that healthcare actually struggles with. Like all of these four things are probably the thing that healthcare struggles with the most. So again, this is why I'm excited about innovation and new technology and tools and stuff like that. They don't come without risks, and we'll talk a lot about that, like data bias and algorithmic bias and all this stuff. We'll talk about that later, the last half of the course. But to me, these represent the areas that I think people are just going to start expecting. And in New Mexico, as patients, we're at a little bit of not a loss, but like we're not as well-resourced, and there's not as much healthcare competition as larger markets. So like if you go to New York City and there's, 3, 4 hospitals within a 5-block radius or whatever, those hospitals have to basically compete on consumer experience and technology and all this stuff because they want you to come to see them. Here in New Mexico, we only have one hospital for many, many miles, and so we don't have as many options. And so I think in a lot of ways that sort of stymies some of the innovation that we have to think through to address patients and consumers. And we're also, we're not as well resourced, and we have thinner margins and stuff like that. And so a lot of times, if we talk about a new technology, well, it's either a new digital health application that we can try to test, for our diabetic patients, or it's like a new X-ray machine that we need in the, in the ER or whatever. So there's very real choices right now. But I do think that this is really driving sort of where the industry is headed. And again, as we start to think about in that system, how do we start to chip away at some of these on a smaller scale? Like maybe that can lead to some bigger impacts here in the state. I don't know. I would love to hear you all's perspective as a patient or just, a New Mexican. Have you come across or run into any of these? Which of these priorities do you feel is like the most broken, is most interesting to you? Is an area that you think that we could do better, maybe even do better through technology with? What do you guys think?
I think access for New Mexico is a big issue right now. Like finding a provider, getting in with that provider quickly is an issue.
Robert agrees. It's interesting. We had so on the access thing, I think I agree with you, Trevina, and others. I think that access is one area that technology is. It's not low-hanging fruit, but it's certainly an area to explore. That like how could that expand access? It was interesting during COVID. I don't know if y'all have heard telehealth or used telehealth, but it's virtual care or virtual appointments or whatever. This idea that instead of going into the doctor's office, you could like make an appointment and do it on your phone or whatever. Sounds great to me. I've been working remotely for like 10 years and I don't want to leave my house, but everyone's like, oh, that's great. Like we could all get, doctor's appointments on our phones. We can't go into the hospitals or whatever because COVID has everything locked down. So like telehealth across the nation had this huge boom, right? And it is an innovation. I mean, it's obviously a different paradigm from how we do engage with healthcare now, right? So telehealth saw a huge boom. They had to like scramble to get all these policies in place so that telehealth providers could operate across states, could get paid across states, could have like if they were credentialed and licensed in one state, they could practice here in New Mexico, right? Then there was like a whole technology component because not every provider was set up to be able to take a telehealth appointment. There was a lot that went into that, but yeah, it completely spiked. And so everybody's really excited because a lot of people have been talking about telehealth for a long time as a way to expand access through technology. Well, it's interesting that kind of sort of after COVID, and actually I might still have some data on this I could probably put as a resource if anyone's interested. We actually started to see telehealth started to dwindle again. And I haven't looked at it in recent years, but I've really to venture that it's probably gone quite low again, except for what we call behavioral health or things like counseling and mental health services that did still seem to stay high. But it was so interesting to me that, we always thought this like cool technology would really expand access and answer all of our problems. And then we also found that patients in, like rural communities that don't have bandwidth, they don't have cell phones, they don't have all these things, they can't use their stuff, whatever, like they weren't able to engage with it. So I think technology holds huge potential, and I think the telehealth example is a really great example to think about, okay, what lessons did we learn? Was it tailored, for New Mexico's reality? Was it designed for people to engage with it in ways who have never engaged with virtual care or their cell phone before? Like, what kind of infrastructure issues are there? Like, who's going to be left out on the margins of this? Because and I actually did an analysis on that, particularly post-COVID, when I went back and looked at what kinds of communities and what kinds of regions were like the highest adopters of telehealth, even Albuquerque. It actually ended up being largely like Northeast Heights, by and large, was like the number one users of the telehealth services, and like a lot of the other like more less affluent neighborhoods did not have nearly as much telehealth utilization. So that was really interesting. But I do agree with you, Trevina. I think it holds huge promise to extend care. And I'm always like, how do we extend care with technology to the people who need it? And how do we get them, how do we enable them to be able to use it and benefit from it? So another interesting kind of thing coming out now is the Chat GPT Health, where, I think patients are turning to AI for some of these things, for access and for clarity, faster than healthcare can keep up. So it's just a huge area of opportunity, but it does bring up questions like how do we roll that out responsibly and ethically and inclusively? And we'll talk more about that in weeks 8 and 9.
Just a quick question, because you mentioned it. You mentioned that we'll talk more about it, but I'm curious how secure that is at all.
Telehealth?
Yeah, no, not telehealth, but like the Chat GPT.
Oh, yeah. Actually, I haven't dove into that. I think at a high level, they're claiming that that's secure. They're claiming that it's HIPAA compliant. You can feed your medical record in and all of this stuff. Where the question comes in is sort of like, what are they doing with that information? How are they using it to train other algorithms? How does it sort of trickle its way into other things that you might not, realize? They are claiming that's HIPAA compliant. But I don't know. I'll have to look into that and see. I mean, at a minimum, to work with patient data, you're going to have to be HIPAA compliant, but there's lots of other sort of ethical and broader concerns with it, I think, beyond just the HIPAA compliance that are really getting a lot of people up in arms. Actually, that might be a good use case too to talk through in one of our lectures.
Stephanie, got a quick question about that. This is Robert.
Yeah.
When you're saying using ChatGPT, are you saying companies that are using ChatGPT, so company XYZ, you're giving them your health information and then they communicate with ChatGPT, or are you talking about people directly using ChatGPT and giving ChatGPT their health information?
Oh, well, this is a great question. I would say either both, but OpenAI Health or ChatGPT Health or whatever they called it that they just launched, that was, I think, intended more as a direct to patient, where it was like the idea is that the patient could upload all of their own personal medical record directly and then like get their questions answered, help with diagnosis or what, like chat with it just like you would on ChatGPT about something else. So I think there was a direct to patient aspect with that. But you bring up a really, really good point, which is some of these third party or kind of twice removed kind of groups, whereas like maybe I'm a user of a digital health app. Yeah, it's scary. Yeah, this is where some of these ethical things come in, maybe. But like maybe I'm a user of that diabetes education app or whatever that I mentioned earlier as an example. Well, are they connecting to something on the back end and using some kind of a GPT layer? And now it's got my data and I didn't know. There's lots of like trickle down things. So, I mean, so both. And it's getting kind of crazy right now because a lot of times we may not know, and a lot of us don't really read the fine print sometimes signing up for stuff. But this is the topic right now, is how and what they're being used for.
Yeah, regarding that fine print, definitely read that fine print. This is something that I actually have my class do because I encourage them to use generative AI, the ChatGPTs and the Geminis and so forth. But they do need to be familiar with the privacy policies and the terms of use that these companies have. Some of them, I mean, if you've got a paid for plan, for example, with Gemini or ChatGPT, then there's different rules. But by and large, the how would you say, the free versions of these tools, basically when you upload the data, it becomes, you give them I forgot exactly the terms, but exactly an unrestricted license for them to use that data for further training. So
yeah,
be mindful.
It's a wild paradigm shifting time right now. It's transforming things in all the ways. And I'd be excited to talk a little bit more about this. We'll talk a little bit more in week 9 about some of the biases in the underlying data and some of the ethical, concerns and considerations. But the way that this conversation ties to your capstone is because we've modeled the capstone like a digital health app or a technology vendor evaluation. that's based on, an analysis of needs and then into an implementation plan. As we think about how we're going to evaluate some of these tools and technologies in our capstone, a framework for that, we're going to think about some of these things. How do we talk about privacy and security? How do we talk about ethics and equity? How do we ensure that things are, safeguarded? Questions that we haven't maybe always had to ask as deeply in the past. Great
Cool,
questions,
thanks.
great thoughts. So yeah, absolutely. Thank you, Robert. All right. Okay, so let's take a quick break. Let's see, it's about 5:05. Let's come back at 5:10. I know that was a lot. I think I'm going to stop here because we've had a lot of really heady information. I want to spend the last 15 minutes or so going over the capstone worksheet and talking about week one's activities. So let's come back at 5:10. My dogs have been locked out of my office for the last 2.5 hours, and apparently they've decided they had enough.
That's what I was just dealing with as well.
Yeah, I don't know. You all were just barely got into Brightspace because of all the issues that they were having, but I posted a picture of my two monsters, and I swear it's like every time I start talking, they know that's when they need to start barking at something outside. Like, but Zoom has pretty good bark filters.
Well, that's good to know. I really like the palm tree there.
Yeah, Abdul Wakil, did you travel while we were gone to somewhere better?
Yeah, that was in the Florida there. I
Oh,
took that while
nice.
I was in Florida.
Oh, nice. What part of Florida?
Yeah. In Hollywood Beach. I actually, funny because I had checked into a hotel near Miami Beach, but there was like so much going on there that I was like, I need to go someplace a little bit more kind to my sensibilities. So that was Hollywood Beach. So that's where I took that picture
How far is that from Miami Beach? Is that close at all? I've never been there.
at.
Hollywood Beach.
I couldn't really tell you. Like, I don't really recall. I just know, I think it's north of Miami Beach,
Yeah.
and um, it might have been less than an hour, but
Okay.
I mean, drastically different.
Oh, I bet. Miami's a whole vibe. I am. I'm from
Yeah.
Jacksonville, Florida, which is almost in Georgia, really, right along the coast. But I took my husband to Miami for the first time, like in the middle of summer. Just like a huge mistake. It was so hot and humid. And my hair was like, 4 times the size or whatever. And I'm like, man, I don't know what people see in Miami. It's so, I mean, it's probably an acquired taste and an acquired climate for sure. It was fun though. I'll have to try my Hollywood Beach next time.
When you're young and you want to have fun, or even if you're older and you want to have fun, I mean, it's probably a nice place to be. But yeah, it's a lot going on, too
Yeah,
much.
a little too much, yeah. Cool. All right. Do we got folks back? Okay. I just quickly want to talk about the capstone and then we'll talk about next steps if you guys want to schedule time in a little bit of next week. So let me share. Okay. So just to kind of wrap, we were talking a lot about the patients, we were talking a lot about the issues. This is kind of just another review of what we talked about. We talked a little bit about some of the stuff that patients are starting to expect. Again, to me, these are areas to innovate. But the reason I wanted to bring this up before the capstone is these are also areas where we could have something that in healthcare we might call like an intervention. And a lot of times those things might be the same. So if we're like, oh, hey, we're going to be innovative and we're going to launch this, I've been using it, this diabetes digital health app. We send a scale to patients. They use an app to log, all these things. We'll use predictive model, all these things. So that's like the innovation, right? The digital health app or innovation. Well, that is also a health intervention, an intervention because you're trying to change some health outcome. And so you might hear me use those words a little bit interchangeably, intervention and innovation. But your capstone, the whole way that it's designed is for you to identify an area of need or an area of interest based on some data, and then choose a digitally enabled technology or solution or intervention of some kind. And then we're going to evaluate it, and then we're going to kind of make a a hypothetical recommendation to like future decision makers. And so that's how these things come together for our capstone. And so these are some areas you can start to think about. Certainly, there's many, 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 many more. And I would encourage everyone to kind of create and think about a capstone project that's important and meaningful to them. And I'm going to kind of walk through it with you all as well. So with that, let's just spend the last 10 minutes or so on the on the capstone document and on week 1. I have put these capstone activities due on Monday of next week, every week. I know some of you are going to be following along really closely and and want to kind of keep up and do it. again, there's no grade or anything. And so like if if you fall behind on a week or whatever, there's no real penalty to it. I just would encourage you all to, if you are going to do the capstone, to follow along each week because it could be a lot to do at the end. And the goal of it really is so that you all have something really concrete to put into your portfolio at the end of this class that's like meaningful, timely, relevant, and shows potential employers how you approached a problem, how you thought through it and what you recommended. So it was really designed with that in mind. So again, you can go as deep as you want or as high level as you want, but if you're interested in it for like employer and portfolio, like let's definitely talk and make sure it's something robust. Okay, so we'll just start on week 1 here. Okay, so the first week, this is a kind of a sort of an easy one. Remember, if you don't know something, you can make an assumption. We're not going fully into engineering specs. This is a critical thought exercise. So our first step for weeks 1 and week 2, I really want you all to think about, like, as I've been talking about innovations and interventions, like where do you want to focus and like what kind of thing do you want to focus on, and guided by some data. So I kind of try to time these where hopefully this doesn't take more than an hour, of your time. But as Trevina said, the deeper you want to go, the better. And I'm here to help support you. So I kind of broke them out into 2 things. So for each of the week, there's kind of just what I call kind of the core, deliverable or the core assignment. And then there's like a stretch assignment if you want to push it a little bit deeper. So for week 1, we're keeping it fairly simple. I just want you to think about a location. A city or a county usually works best. I'm going to pick Jacksonville, Florida, because I just mentioned I'm from there. It's where my parents live. And I'm going to be kind of talking through this capstone each week with you all through my lens of my little project. So I'm going to pick Jacksonville, Florida, because I don't really know a lot about it, the healthcare landscape, okay? And for week 1, what I want y'all to do is think about your place, Jacksonville, Florida. You can also, if you want to narrow it to like a population, for instance, if you're really interested in Medicaid, you may want to say like Medicaid recipients in Jacksonville, Florida, or Florida or whatever. So you can add a population view, but I think the easiest is a place. And then I want you to start thinking about 2 or 3, what I'm calling candidate issues. So these are like health issues or challenges or topics or problems that you're interested in. So somebody mentioned like a congenital heart thing in the chat. So those, you maybe might be interested in looking at something like that in the area. I'm going to pick for mine as an example because my dad was recently diagnosed with prostate cancer after, and he's in his 70s. He had a lot of failures leading up to the point where I feel it could have been identified earlier. So I'm going to pick as my issue, like cancer, prostate cancer, and screening. Okay, those are kind of big level buckets. I don't know if they're issues in Florida or whatever, but like I know that happened to him. So those are kind of the big candidate issues I'm going to look at. And what I would like you guys to do for week 1 is to start going in. I've provided some data resources, and I can provide more if you want to, if you email me if you're having trouble finding something. I just want you to start pulling some different what we'd call indicators or measures or data statistics about this issue that you've picked in your region. So for example, I'm picking Jacksonville, Florida, and I'm picking, let's say, prostate cancer as my candidate issue, and maybe breast cancer is a secondary issue I want to consider for my topic, right? I'm going to go in, I'm going to start pulling some different data, looking at different data sources about what's the prostate cancer rate screening per 1,000 in Jacksonville. Like, do they tend to be low or high? Are they meeting certain standards? How does that compare to New Mexico? So I can contextualize it. Like, do we see higher instances of cancer rates in male or female? Well, those ones are probably bad examples, but you know what I mean? I'm going to start pulling some indicators in my area based on my topic. And then based on what I see in this for this week 1, the whole goal of this is to then use that information to say, okay, based on what I've pulled, it looks like this, prostate cancer screenings or whatever is like kind of an area of interest. I'm going to focus on that for the rest of the capstone, and then I'll design my intervention and my digital app and all that stuff around that. So this one's kind of a very wide, very broad. You have a lot of freedom, a lot of areas you could take it, but that's kind of how week 1 is. I've listed some example candidate issues if you can't, you don't know where to start. I've listed some example indicators if you're, trying to think of like what might illuminate that challenge with data a little bit more. And And then I've tried to just provide some structure, around. You have total flexibility and freedom of how you want to kind of structure this and do this. What I might recommend is at the end, because we're going to do, we'll present our capstone projects, is maybe like a slide or 2 or 3 or whatever you end up, just kind of showing your data or thinking through it. The alternative is you could kind of put everything kind of as a brief, like kind of just keep appending week after week. But we can talk a little bit more about format. But for now, it's a thought exercise of finding some public data in the open domain, sort of honing down your area of interest and sort of picking a topic that maybe is important to you, but also a topic that shows by the data that this may be an area that you could want to possibly target and improve outcomes through an intervention of some kind. Oh, and yep, Gary wants to do something with congenital heart. Yep. Interesting. That might be we might need to talk about that one because it's so specific, but yeah, let's talk a little bit more. We can brainstorm. So I'll stop there. That's for week 1. You have some resources here. I have a list of 100 open source health data sets that I've used in the past. This was pre 2026, and so I don't know if all of them are still up and working, but it kind of gives you an idea of how to look for certain data sets. I would also encourage you to look at this. I have this other guide, how to do a community health needs assessment. It shows you how to use some very high level, very broad public health data to quickly kind of narrow down topics or areas of potential interest within a region. So I would look at that. Of course, I mentioned if you're going to do something in New Mexico, Department of Health has a ton of stuff, a ton of data. Susan and Graham probably know way more about that data than I do. CDC Places is a good one. And I actually would have you peek into week 2 resource. I actually did a long time ago for fun after I visited it, Hawaii. I was like, I wonder what the healthcare system's like here and what kind of issues and challenges and how it compares to New Mexico. I was just really curious. And so I went through this whole kind of almost a similar kind of exercise where I was looking at different sources and kind of going down a breadcrumb trail to identify some areas that they might be struggling with that would be some areas for innovation. So I would maybe jump ahead and I would encourage you to check out that data profile. At the end of our capstone, I'm hoping that you all will have something similar. Mine's written more in a narrative format, but that data profile is really an analysis that you can kind of show and showcase and use as part of your portfolio. So I will also post as an announcement or a discussion or something, a link to my calendar. I have certain time blocks open for our one-on-one office hours. I am available in here as you all need. If you want to brainstorm or talk through something or look for stuff or do a working session together, I will offer that to you. If you get stuck, email me. So I'll send out that calendar invite if you all want to talk a little bit deeper. So that's week 1, and we're aiming for Monday to have that one finished. And if you want feedback from me or guidance, get it. If you submit it, you'll get some thoughtful feedback and some pointers and some considerations and stuff to kind of help you craft your thinking too. So I'll stop there. What questions do you have? Okay, cool, Gary. What questions do you have for me? Is that clear? Where do we submit the updates to the sections? Oh, like your deliverable for the week? Like your slide deck? Is that what you're asking, Abdul Wakil?
Yes, sorry.
Oh, okay. My computer's still kind of fritzing out. There is, if you go into the Brightspace, I think I closed it, but there's an assignments section where it says capstone deliverable week 1 or something to that effect. I think you should be able to submit it through that. But I haven't actually used Brightspace in that way before, so let me know if you have any problems. Worst case scenario, just email it to me.
Stephanie, this is Robert. Was wondering, are these individual or group capstone projects, or a little bit of both, or something else?
I have designed it as individual, though certainly if folks want to do more of a group project, I mean, you're welcome to break off into groups as well and do that. Do you have a strong preference for more of a group activity? Or does anyone have a strong preference for that? Maybe would want to solicit some other group members?
I would definitely like to pick some other people's brains.
We could also spend some working time, in our classes too, to kind of debrief. Does anyone else have any interest in kind of more joining a group rather than doing individual?
I'm okay either way. I'm always open for maybe meeting and talking about
possibility of working together. So you could, yeah, anybody want to contact me, or I could give you guys my email. Are we allowed to do that, or we just communicate in the?
Oh yeah. Actually I needed to ask everybody. If are we is everyone okay if we share email contact information with anyone? Is anyone not comfortable with that? Let me know in the chat. If everyone's okay, then yeah, we can start kind of a group. I can handle that. I mean, I can get everyone's contact information out for everybody. So Robert, maybe it might make sense for you to sync up with Abdul Wakil and see if maybe there's some opportunities to work together. If anyone else is interested in more of a group activity, email me and I can kind of solicit and see. And then you all just let me know. But yeah, I'm definitely, and Gary, it actually might be good because you kind of are focusing on that real niche kind of topic. I'm wondering if the power of kind of a group might help with some of that brainstorming thoughts. Yeah.
I'm definitely open if anybody wants to work with me on that. I'd be happy to share as much information as I can.
Robert, how does that sound? Do you want to maybe kind of take lead on reaching out to
Yeah,
those folks?
I'd love to reach out to a few different people if you don't mind.
Okay.
If they don't mind.
Sure. What I'll do afterwards is because I got to share my calendar link, I'll send my calendar link and I'll send everyone's email address. I think most of you all said you preferred your personal email because you're probably not checking the CNM email as much. So I'll include your personal email that I have. What other questions do you all have? Anything else? All right. Next week, we will continue in our ecosystem, and I think we'll start doing kind of more of an actual formal like money and data tracing through the system. So if you have any questions, email me. Otherwise, I think we are good to go. Thank you all for a wonderful first session. I'm super excited for the next 9 weeks.
Thank you.
Likewise. Thank you.
Yeah, thanks.
Bye.
And nice to meet everybody.
Bye.